Population Health Management Initiatives. My name is Dr. Nathan, and I will be co-moderating this evening's session with Dr. Bob Pyatt as we are co-chairs for the ACR's RLI Power Hour webinar series. Before we get started, there's just a few logistical items that we do want to go over with you. So when you join this evening's event, you join through the Zoom platform. At the very bottom of your Zoom window is the Zoom control panel, and here's an image of it here that I'm circling with my cursor. There are two icons that we want to draw your attention to on this control panel. The first is the chat icon. When you click on the chat icon, up comes the chat window, and you would use this if you have any sort of technical issues. So type in your technical concern, hit send, and then our support staff will be reaching out to you to help you resolve your issue. The second icon we want to draw your attention to is the Q&A icon, which I'm circling right here. This is an icon that you would use if you want to ask questions of our faculty. So you click on the Q&A icon, up comes the Q&A window, type your question and hit send, and we will then see it on our end. You are welcome to submit questions at any point during the webinar. However, they will only be collected and not addressed until we get to the very end of the webinar at the dedicated Q&A portion of the session. One other item that we do want to let you know about is that this is a recorded webinar, and that also includes the Q&A session with the participant questions. This recorded webinar will then be available to our membership at a later date. So I'm now going to turn things over to Dr. Pyatt to introduce this evening faculty. Dr. Pyatt.
Thank you, Jen. It is quite an honor to have 5 fantastic faculty presenting tonight. And we'll start off with Dr. Ryan Lee, who will be also helping to moderate some of this evening's program. Ryan is the chair of radiology in the Einstein Healthcare Network. He attended Cornell University for his undergraduate degree and attained his medical degree at Drexel University College of Medicine. He completed his residency in diagnostic radiology at the University of Rochester and his fellowship in neuroradiology at the University of Pennsylvania. Ryan also has an MBA from the Simon School at the University of Rochester. Dr. Kate Behan serves as the Senior Vice President and Chief Population Health Officer for Jefferson Health, leading Jefferson's strategy and implementation of value-based care. She has over 20 years of experience in the healthcare industry, holding various roles of increasing responsibility at several organizations, including Jefferson. Prior to this role, she served as the Chief Medical Officer of the Jefferson Northeast Physician Practice, as well as the VP of Clinical Effectiveness. Prior to joining Jefferson in 2015, she was Enterprise Senior Medical Director for a Medicare Advantage health plan. Her responsibilities included clinical oversight over the Cigna Medicare clinics in several regions. She was the clinical leader of one of the first innovative care models in Philadelphia, the Bravo Health Advanced Care Centers. As an internal medicine specialist, she has worked as a primary care physician and as a hospitalist. Our next faculty member is Dr. Rodney Ison. He attended the University of Kentucky for undergraduate and medical degrees, and his residency program was completed at Barberton Citizens Hospital, now Summa Health, Barberton. He served as CEO of the Community Healthcare Incorporated since its inception in 1986. Growing it to include 17 offices with 37 providers. Dr. Ison participated on several health organization boards, including being a founding member of Summa's ACO and serving as the chairman of the board for 10 years. He currently serves as a vice chair for the ACO at Akron Children's Hospital and director of practice management curriculum and part-time residency preceptor for the Barberton Area Family Practice Center. Excuse me, at Summa Health Barberton, and also as a volunteer at Faithful Servants, which is a faith-based urgent care center in Talmadge, Ohio. Dr. Elizabeth Rula is the executive director of the Neiman Health Policy Institute, which has the mission to establish evidence to inform health policy and radiology practice that promotes the effective and efficient use of healthcare resources and improves patient care. With over 15 years of experience leading health services, economics, and outcomes research, Dr. Rula strives to establish a strong scientific foundation for the value of healthcare services and health policy that promotes broad and equitable access to high-value care. Our first speaker tonight will be Dr. Syed Zaidi. Dr. Zaidi is the co-chair of the Population Health Management Committee along with Dr. Lee, and this is in the ACR's Patient and Family-Centered Care Commission, the PFCC. He also serves as Associate Chief Medical Officer of Operations and Integration for Radiology Partners, which is the largest physician-led and owned radiology practice in the United States. It is quite an honor to have these fabulous faculty here this evening, and I now turn the program over to Dr. Zaidi. Thank you.
Excellent. Thank you, Dr. Pyatt and Nathan, for the wonderful introduction, and appreciate the opportunity to be with you all and partnering with the Radiology Leadership Institute for this webinar. And I'm just doing a quick 5-minute intro on the work of our committee and how we came to this point with partnering with the RLI. We, Dr. Ryan Lee and I co-chaired the ACR, Patient and Family Centered Care Commission Population Health Management Committee. This was founded in 2019 under the leadership of Dr. Jim Rawson. And we've been engaged in this mission along with our administrator, Chris Hobson, and for the leadership of the PFCC Commission Chair, Arun Krishnaraj. Our mission is to engage radiologists and stakeholders on the importance of the role of radiology in population health management. And we're obviously collaborating with other ACR leaders, economics, and PFCC internal groups and other stakeholders. And I think the key is to be able to collaborate with other population health management leaders so that we can share the experiences. And that's where this webinar was conceived, that we're actually going to have 3 non-radiologist health system leaders from private practice to academics and the ACR HPI to help guide us as to the role of radiology in population health management. And one basic definition of PHM is taken from the Institute of Health Technology Transformation. There are lots of different definitions. This is one that appealed to me, that the goal is that we want to keep a patient population as healthy as possible. And we want to minimize the need for expensive interventions. And you notice that, along with ER visits and hospitalizations, they threw in imaging in there as well. And I think that's important to figure out, is imaging actually a cost in the PHM model, or is it actually a driver to drive downstream savings? And PHM requires a lot of new skill sets, infrastructures, automation and artificial intelligence can help make this scalable and sustainable. So we're going to share some examples of all of those. And I know that Chris Hobson will be putting in some links into the chat for past webinars that our committee has been leading as part of educating and engaging with radiologists around the role of radiology in PHM. And this is a graphic that our committee has developed around trying to visualize population health management and the different buckets, right? So you have the surveillance and prevention bucket, where someone is, and I'm sorry, it looks like a slide got skipped there, but that's okay. So the surveillance and prevention bucket includes mammography, low-dose chest CT, virtual colonoscopy, and AAA screening. And this is an area where radiology needs to focus, and we're going to have some examples of how we can improve there, particularly in low-dose chest CT. Then you have the acute care arena, where we know about the role of ACR Imaging 3.0. That's been a sustained effort since 2013 under the leadership of Dr. Allen and Dr. McGinty. Obviously, the Choosing Wisely initiative, which is a broad healthcare initiative, and you're going to hear about that today. The role of clinical decision support and how we can actually manage utilization that way appropriately, and also care coordination efforts. And then the final bucket is chronic care management, where we need to be following up on incidental findings that are important, such as AAA lung nodules, and be involved with oncology interventions such as IR, as well as other incidental findings where we don't normally make these diagnoses regularly, but they're very important to patients such as fatty liver, metabolic syndrome. This is the opportunistic imaging, and you can see this webinar that was done by Dr. Krishnaraj in partnership with our committee. And just wanted to highlight this quickly. Members of our committee and as well as others participated in a manuscript with the American Journal of Rentgenology, which was basically an expert review of the radiologist's increasing role in population health management, just published this year. And I'm not going to go through all of these conclusions, but it's something worth reviewing, where we were able to review a wide array of strategies of PHM, and I think there's a lot of possible initiatives that we should target. And on my last slide, this is what I advise people about how to look at population health management as a strategy, approaching it from the radiologist point of view. I think that COVID has shown us that we need to get off the fee-for-service train. Reimbursement cuts are here to stay. We often feel like we can keep up due to productivity and technological improvements. But I think COVID showed that the paradigm is really changing. We need to partner with the health system as well as the PCPs on taking risk. You'll hear from one PCP leader who is doing exactly that. We need to invest in care coordination proactively ourselves. And we should work on the demand side of imaging, not just supply. There's a short staffing in radiology currently, probably for the next few years. But how about we work with clinical decision support and making sure there's appropriate imaging being performed? We should use AI to improve quality and not just focus on productivity, as well as use it for opportunistic imaging, build out new services that we can perform for our patients. And I think that groups that have a population health management strategy proactively will outperform those that don't. If you're just relying on the government to tell you what to do and waiting for everything to be defined for you, then you're going to be waiting a very long time and may miss out on the boat. And because excellent patient care is the best business model, if you're a radiology group or you're in a multi-specialty group or in academics, where you know that there is a lot of trust between the clinicians and you're providing team-based care, then build the business model around that. We don't need to wait for very defined alternative payment models from the government. So that's a short introduction. Thank you. And I'll turn it over to Dr. Lee.
Thank you, Dr. Zaidi. While Dr. Behan gets her slides up, I just want to also echo what Syed just said and thank the Power Hour crew, Dr. Pai and Dr. Nathan and Jen Pendo, Chris Hobson as well, and Anne-Marie Pasco for having us here tonight. It's fantastic, and we're looking forward to the great talks in line. And Syed and I specifically wanted to get a population health perspective from other individuals other than those primarily in radiology. And I guess Elizabeth Rula also fits that, and she fits multiple buckets. But we've had multiple webinars, and a lot of them were radiology driven. And this is our opportunity to really look at the bigger picture of population health and see where radiology fits in it. So with that, Dr. Behan.
Great. So thank you, Dr. Lee. Really glad to be here tonight and appreciate the opportunity to be part of this webinar and looking forward to the conversation. So I'm going to sort of go over some of the basics of value-based care, and some of them you may be aware of already, but I just sort of like to start with the basics and then talk a little bit about how our payments in the US have actually shifted from fee-for-service to value-based care arrangements. Talk a little bit about some of the positive things of value-based care, and then finally talk about how radiologists can participate in value-based care. And I know that some of the other speakers will be talking about some of these things, and in particular, we'll be hearing from a radiology group and a primary care doc in terms of how they work together. So looking forward to all the conversations. So, really what is value-based care? And really, it depends on who you talk to. So, from my perspective, when we talk about value-based care as a health system leader, but also have been worked in health systems and payers, I'm going to be talking about it tonight in terms of the actual how we get reimbursed. And so it's that volume to value conversation, right? In terms of, instead of getting reimbursed for volume, the more you do, the more you get paid. This is getting reimbursed for value, right? And there's different permutations and combinations of that. So providers get incentivized to actually help patients improve, right, in terms of their overall outcomes, their actually management of their conditions, chronic diseases, and ultimately live happier lives and healthier lives. In arrangements, it's typically providers. And when I talk about providers, I want to clarify that that could mean anyone from a health system provider. It could mean a private physician group. It could mean an employed physician group. So it sort of is a generic term that I'm going to be using. And so those providers contract with payers such as Medicare, Medicaid, and commercial insurance to care for a defined set of patients. And usually there are a defined set of metrics within that kind of arrangements that need to be met. And then finally, I like the description with the prior presentation in terms of population health management. Population health in itself is a term that is used to describe many different things. And I like to think about it as really kind of a way that enables success in our value-based care. So let's talk a little bit about some of the common more common, I would say, value-based contracts or arrangements that are out there. You probably are familiar with some of them, but just wanted to cover them. So shared savings, again, this is still fee-for-service is built into this model, and that is largely the way that provider will get reimbursed. However, there is also a set amount that is based on, how well the providers perform on certain set metrics and meeting, medical cost targets, for instance. And so then the provider has an opportunity to take part in those shared savings. Shared risk is actually also known as downside risk models, right? So that's where the provider also, in addition to actually maybe getting some shared savings for positive performance, they also take on a little bit of risk in terms of performance that actually is falling below the set metrics. And so this is one where you potentially can earn more dollars if you do well, but also there's also more risk in that you're financially accountable for some of the medical costs around that population. And then bundles. So bundle payments are really where healthcare providers are have a set payment target to meet an episode or to cover a certain episode of care around a designated population of patients. And importantly, that amount does not change. It is set based on regional standards and the risk of the population. So it is adjusted along those lines. But if there's a set amount, and if it's, let's say, for instance, a CHF bundle, that typically would, from CMS, that's 90 days. So anything that happens in that 90 days, whether there's 100 MRIs ordered, which I know is kind of silly, but I just thought I would throw it out there, or 0 ordered, you would get the same amount of reimbursement. So it really encourages all of the providers who are participating in the care of that particular patient to actually work together and encourages collaboration and really aims to reduce unnecessary or redundant care. And then finally is global capitation. And we actually are seeing some of these models out there. So this is where the provider takes on full risk. So the providers get a set amount of dollars. And that is, again, based on the population. It's risk adjusted. So again, for a higher risk population, you probably will get more dollars to take care of that population. But again, it is a set amount of dollars. And so at the end of that particular agreement, you may end up owing money if your group is performing under the set targets. And so that is really full risk in terms of financially. So, this is a graphic I like, and this is a healthcare payment learning action network, and I like this group. It is a consortium of payers, policymakers, and providers, and really was founded, I believe, back in 2015. And really, their overarching goal is to advance value-based care. And so these categories that you see are really a little bit what I've just described. And with one category, one is that old traditional way that we get paid. A lot of us still get paid that way, but there's no link to quality and value. So that's kind of the volume kind of end of it. Category 2, you're moving a little bit more into linking that fee for service with quality and value. 3 is actually now taking an opportunity to get shared savings. So you perform well as a provider, you may actually get some of the shared savings if you actually reduce medical cost. And then there's also that downside risk that we just talked about. And then finally, category 4 is that population-based payment. Sometimes it's also referred as capitation payments. So, there's an assessment in terms of the risk of the population, benchmarks in terms of prior payments, and then a set payment is given to the provider. Usually, sometimes you hear it referred to as PMPM, so that's per member per month, or sometimes per member per year. And that is where you are fully responsible for financially, both medically and financially, for that patient population. So how are we doing in terms of moving from the old volume to value? So this also is from the HCP LAN group, and they surveyed many payers across the country. And in the measurement year for 2020, they found the response was that about 41% of U.S. healthcare payments, representing about 239 million Americans, and which was about 80% of the covered population, went through categories 3 and 4. So those are the more advanced, categories or value-based care arrangements. And so certainly that has been, they started measuring this in 2015. If you look at their site, you can see sort of it's gradually gone up over the past several years. It's not gone up as much as they projected it. Lots of things contribute to that. Not, of course, pandemic is a big one. You can also see too, by the different lines of business, if you will, for payers, right? So the commercial population, which tends to be, largely employer sponsored and paid for plans. You've got Medicare Advantage and traditional Medicare, which are those over 65 are eligible for Medicare and then Medicaid. And you can see that there's a lot more uptake in our Medicare populations. And really that's basically because CMS is really pushing value-based care models. And then, by way of that, so is Medicare Advantage. So Medicare Advantage is that quote unquote privatized Medicare. So before we go further in terms of talking about value-based care, I think it's really essential that we talk about health equity. Just like our healthcare delivery system, we have not done a good job at addressing health disparities and really kind of thinking about health equity. That is the same for value-based care. And so CMS, certainly on the heels of the pandemic and everything that we saw in terms of health disparities that were really I think brought into the forefront, they're quickly trying to integrate health disparities, addressing health disparities and health equity within their models. The first attempt of that is really the ACO REACH model, which just came out several months ago. And again, it is really focusing on addressing health disparities. And I think, we'll see how that works out. It was kind of quickly designed, but I think important that they got it out there. In addition to that, even the private payers are really looking at this. You can see the survey information on the right-hand side. They're either attempting to sort of think about this by just starting to collect data, and that's not easy, right? Because we typically don't document all of this on our patients. And then also work with systems providers actually to support work around health disparities. So really important. We'll see more and more of this, and it will really be in everything that CMS is doing and even our private payers. So some good things about value-based value-based care impact. So, even since the Affordable Care Act in 2010, I've been out of residency for about 20 years now. I've seen a lot of changes in terms of, where I sit, things that we never had before, you never thought about during residency that you have now. So care coordinators and who actually are taking care of patients, not because they're acutely ill, but they're trying to prevent them from becoming sicker. So, there's been a lot of work in terms of reducing adverse events. And, some of the CMS penalties and value-based purchasing have gone a long way to do that. I think that there's much more willingness and adoption of evidence-based care standards and protocols, and integrating that within health systems workflows and also provider workflows. The focus on highest risk patients, right? So we've all heard sort of the highest high amount of dollars that is spent on a small proportion of patients. And really, what value-based care has done is to try and address that, and really focus resources on those high-risk patients, to invest in them and invest in their care, so that hopefully you can actually prevent them from getting sicker. Hopefully you can prevent them from having, instead of having 10 hospitalizations, maybe they have just 8, right? And that's a good outcome for the patient. Team-based care model, there's going to be a lot, we're talking a lot about that, I think, in all different areas, not just value-based care. But I think certainly value-based care supports this, and really, at its best, this is professionals practicing at the top of their license. We still have a lot of work to do there. It's very complicated, certainly impacted by the workforce issues that I think that everybody is aware of as well. Care coordination, again, talked about that. We really didn't have that, right? You didn't have outpatient sort of teams working to prevent and support patients in terms of preventive care. And then finally, improved access and increase in preventive care. And I know that for radiology, mammography is really a big win. We really improved our screening rates. We've improved access. Still a way to go. And actually, I think in terms of addressing the disparities in terms of that access, we've got some work to do as well. But I think, we've made some progress. So, what are some of the challenges in terms of getting there? Number one, the provider has to be willing and ready to do this. It may be much easier to kind of, count on those fee-for-service dollars, because, if you have to perform to actually earn dollars, that might be much more difficult. It requires a lot of investment in the resources to succeed. There's sometimes no reimbursement for non-direct care, so that care coordination aspect of it typically is not sort of paid for. And so that requires either, paying for that by revenue earned in value-based care, or an investment from the provider group or the health system. We are seeing some payers, though, actually, including CMS, who are actually paying for some care coordination fees up front, so you can build that infrastructure. So that's a positive thing. CMS, so lots of models out there. If you don't sort of know, this world, it gets very confusing. Which models should you be part of? How does it overlap with this one? So that gets very complex as well. And you do need folks who know what they're doing and understand this to really help you decide which ones to participate in. We've all heard about the regulations, not just in value-based care, but in general, and reporting complexities. And that certainly actually takes a lot of investment, but also work to get that done. And then once you're in programs, measurements are complicated, right? You kind of have to figure out what do you need to do? There's 10 things you need to do to meet this measure, and it gets complicated. In addition to that, when you perform well, right, it's hard to keep that sustained continuous improvement up, right? There's only sometimes so much you can do to continue to kind of, when the bar gets set higher and higher. And that actually is being looked at by CMS too, because that is a lot of the feedback they've gotten recently about their models. And then finally, last but not least, and relevant to this group in particular, value-based care has largely been attribution-based and attribution-based to the primary care specialty. And so because of that, our specialists, including radiology, have really not been engaged in sort of the value-based care in terms of arrangements and contracting. I think, I think that'll change. I think it'll take a little bit of time to change, but I think that as we advance in value-based care, we'll see that. So radiology, what are some of the programs that are right now? So the CMS MIPS program, if you're not in an ACO, and if you need to submit for MIPS, this really is value-based care, right? So because you do get your fee-for-service adjustment is adjusted up or down based on performance in certain metrics and outcomes. And I know that there are groups for radiology into 3 different buckets, and they do change every year. And so I believe that even, the ACR has sort of some documents on their website that you can take a look at. But again, the adjustment is up to 9%. So if you perform well on these and you're in the MIPS program, you actually can earn additional dollars. Bundle. So I think I talked about that talked about this a little bit before, and again, accountable for the cost in a specific episode of time with set cost and quality. The CMS radiation oncology program, so that has been, twice delayed. And then finally this year, recently, I think last month, the Biden administration said that it's delayed indefinitely. There's lots of reasons for that, and I'm sure this group may be aware of it. I think that there's challenges in terms of on the heels of the pandemic. It also faces potential in this program, potential cuts based on site neutral payments that would occur. And so, I think CMS wants to give it a little bit more time, I think, to think about it and really kind of put it on the back burner because there are other models they want to get out there. Episodic and surgical based bundles. So, this is something, again, when I think about radiology, I think that this would be sort of the opportunity for radiology to participate in, because there are certain surgical bundles. And let's talk about the joint replacement programs, right? So in all of those programs, there's imaging involved in those programs. And certainly, that actually is part of that value equation, right? That value and that cost equation. And so, radiology would be a natural participant in that type of bundle. And then finally, chronic and longitudinal bundle episodes. Those are not, I haven't seen those out there. I think they're more of a private payer, but they're interesting. An example of that might be sort of a bundle around osteoarthritis. And it could be with ortho, right? But you've got a set amount of dollars to cover that patient. It may really encourage, or discourage, I would say, low value surgeries and really kind of putting the patient in more conservative therapies when appropriate. And then radiologists certainly can be in ACOs. And some of you may be in ACOs. If you are in an employed physician group that is part of an ACO, you likely are in the ACO yourself, depending on the structure of your group. And then certainly independent radiology groups can also participate in ACOs too. And then finally, independent groups have opportunities to collaborate with those who are in value-based arrangements as well. Areas of impact. So preventive care screenings, really huge impact that radiology has made, again, first and foremost in mammography screenings. I think there's continued opportunities in that area. I think coordination of care. So, working with patients directly in terms of accessing their results. Many health systems with EHRs have a patient portal and can be done that way. If it's an abnormal result, again, not always feasible, but it actually could be communicated to the patient directly if that referring provider is not available. And then I think communication with the referring physicians and providers and being available for consult for questions, improving access. So this is, I think this is a big one, right care at the right time, at the right place, and really avoiding acute care potentially. And that is, as an example, being able to actually get a patient over from the office to get an X-ray, that day, and or an ultrasound that day to make sure that they don't have a DVT or pneumonia, and instead of potentially sending them to the ED. I know that as a primary care doc, if I couldn't get them in, I was worried about them, I would send them to the ED. But again, with great access and communication with our radiology partners, I think there's a big opportunity, and it's good for the patient too. And then finally, as your expertise in terms of the work that you do is, guiding and managing utilization of resources. And that's, there are multidisciplinary teams in hospitals and acute care rounds. The clinical decision support system, which I know is a big topic, improving, again, educating on an appropriateness of imaging and reducing duplicate imaging, evidence-based management of incidental findings, and actually offering those those to your referring providers, is sort of a great way to guide and lend your expertise. And then finally, opportunistic imaging, which, kind of falls under, I think, the AI. And that's, that's really an interesting one. And I know Dr. Lee is doing some work with that. And I think that it will be really interesting to see how that evolves and is used in terms of, value-based care in general. But it seems like there's a huge opportunity, no pun intended, to explore there. All right. And so I wanted to also give just a few quick examples in terms of what some folks at Jefferson are doing. This is data from Dr. Vijay Rao, who is a big proponent of value-based care. She's our chair Jefferson for radiology. And they were really focusing on utilization of MRI, and took a look at that. They had been tracking it for 20 years, saw it spike up, and then really put some things in place, and they saw a nice reduction. We've talked a little bit about this. So the computerized clinical decision support system, again, depending on whether or not you have an EHR or not, you're in an employed group or a health system or private group, it may be harder or easier to do this, but certainly a great way to kind of manage utilization in terms of the appropriate use. And then wanted to share some work that our radiology group and our ISNT group is pairing up on, using both kind of trying to match the capacity and the needs of the population with the zip code. And it's using digital health, which, many of us have had some great success in during the pandemic. I think it's a great way to engage patients. It's also a great way to kind of, match up that capacity. I know that my team many times have done lots and lots of phone calls to get patients in for mammograms, but only to be met with, well, we don't have capacity to see them. And so that can be a real negative for the patient. They get discouraged and don't do it. So again, I'm looking forward to, I think this also has a great potential in terms of addressing some of our disparities as well around some of these screenings. And that is the end of my presentation. This is a great cartoon I stole from somebody else. And I think that, it's interesting in medicine. I think we often sort of think about other parts of medicine as you get frustrated when you see somebody who's done this and that. And I think we've come a long way in terms of, how we've evolved in terms of ordering tests. So thank you so much.
Dr. Behan, thank you so much for that awesome talk. And what struck me is that how aligned we are. We've been doing things in radiology, attempting to contribute to population health, and I think you confirmed to myself and Dr. Zaidi that we're doing some things and that we may be aligned. So thank you.
Absolutely. You're already doing value-based care.
Well, you also opened up. I have so many questions, and so be ready for them because there's going to be a lot.
Okay.
And I want to keep things moving along. I'd like to introduce Dr. Elizabeth Rula, the Executive Director of the Harvey-Neiman Health Policy Institute. So thanks for being with us tonight, Dr. Rula.
Thank you for having me. Can you hear me okay?
Yes, we can.
Perfect. Well, appreciate the opportunity to be here today in my role leading the Neiman Health Policy Institute. Of course, my lens on this issue is going to be the research that can help radiology effectively contribute and show value in population health models. So I just want to start by reflecting on the framework that Dr. Zaidi provided in the introduction. At the ACR, we're organizing our population health management efforts into three big buckets with initiatives in each of these buckets, as well as those that kind of span across these buckets. And this is really an effective and simple schematic. One of the big challenges in the field of population health is narrowing in on what is population health and what is not population health. A standard definition is that population health is improving the health outcomes of a group of individuals, including the distribution of such outcomes within the group. So as a construct, this is really broad. Essentially improving health outcomes of any group of people and reducing the disparities that occur for some subsets of a population. And in fact, a population can be any population. It can be an employer group or it can be the US population. So when you think about it this broadly, clearly radiologists improve health outcomes in many ways. And the key is to develop and prove that value proposition and identify kind of the highest opportunity areas for radiologists to continue to contribute to these models in the future. So one of the leaders in population health is the Institute for Healthcare Improvement. And this group convened a number of organizations, including the AHA and the Robert Wood Johnson Foundation, to identify pathways for achieving improved population health. What they came up with were 6 foundational concepts that are shown here. This starts with health and well-being that develop over a lifetime on the factors that create health, all the way over to the elusive idea of health creation requires partnerships outside of healthcare. So when I talk to radiologists, some of these concepts can seem foreign or outside of their wheelhouse. But I think we're missing some opportunities to translate what we're doing and our goals in relation to some of these other frameworks. So in this case, I think we are often saying the same things, but just using different words. So this is my translation of these concepts into language that probably feels a little more familiar and actionable to radiologists. So here we know that social determinants drive health and well-being outcomes, and that place where you live, your zip code, is a determinant of health, well-being, and equity. So this ties to a lot of work that radiologists and the ACR are doing to promote greater health equity. The health system needs to address key demographic shifts of our time. A lot of this is the growth in chronic diseases, and in particular with the aging population. Radiologists play a key role here in screening and diagnosis. Then there's the health system can embrace innovative financial models to make these changes. And here we're talking about policy change, where radiology is very engaged. And then in the last piece, it's really about collaboration. And that's something that we need to continue to advance to make sure that we can have the biggest impact. So I want to start digging into some of these areas where radiologists are contributing, and want to start first with cancer screening, because this is an area of population health where radiologists undoubtedly have a central role. So the Healthy People Initiative was started by the IHI and RWJF, and its purpose is to set measurable objectives to improve the health and well-being of people nationwide over the next decade. So they're reset every 10 years. These goals have evolved over time to reflect the current view of population health. So, for example, reducing cancer death rates has been a goal for a few decades now, and it's great that we're seeing some improvement. But more just recently, it was added as a goal to increase screening rates for some of these cancers. So we're still at the baseline phase for these. But when you look at where we are today and what the goals are for 2030, you can see that there is a lot of opportunity for improvement. And this, of course, represents an opportunity for radiologists to get involved. And, it was great to hear how Jefferson is doing some of that right now. And it is, another area is advocacy. And I bring that up because it can be highly impactful in screening utilization based on some of the research that we have done. For example, a recent study from our institute looked at CT colonography rates over time to see what factors have affected the utilization trends. The data showed that there was a 50% increase in CT colonography rates after the USPSTF updated their recommendations to include CTC. And this was, this is a huge leap. This is, I think, as a good comparison point, the CT colonography rates were pretty steady from 2010 to 2016, despite the fact that during that period, there was a significant reduction in patient cost sharing from 38% to 10% within insurers. Yet that really didn't make a difference. So here it just shows how policy can even just create norms that increase rates of screening. But one thing that we have to be aware of is that even when there is coverage and knowledge at the policy level, disparities in access are rampant even among the insured, and this is the health equity issue that we've already been talking about tonight. So one recent study that we published was looking at the use of prostate MRI to look for prostate cancer after an elevated PSA test. The results were pretty striking, with Black patients being 24% less likely to have a prostate MRI after receiving an elevated PSA test compared to white patients. So this is where we have opportunities to reduce those disparities through a variety of different possible options. And one of the things that we're looking at in our institute in terms of improving health equity is that we're really uniquely positioned to try to identify economic policy that can help to improve health equity. So we have a number of studies underway, some of these in collaboration with the Radiology Health Equity Coalition. And we're looking at cancer screening equity. Some of the things that we are trying to answer is trying to understand what the factors are at the individual, geographic, population, community level, and even between facilities that may be sources of disparities that could potentially be overcome through different incentives. We're also looking at newer screening technologies. We're seeing in our data that minorities have much later access to newer technology, such as digital breast tomosynthesis, compared to white populations. And there are a lot of factors that go into this that we're learning about. But we have a big gap to bridge here, where there's 41% higher breast cancer mortality for Black patients compared to white patients. So what we're really digging into is trying to elucidate these sources of disparities and identify where the system can place economic incentives that may reduce the identified disparities. Like, for example, with new technology, we know that that large radiology practices or health systems will often place the newest technology where it is most economically, where they'll make their money back first. And that's just an economic decision. But as a result, the new technology goes where there is a more favorable payer mix, which creates disparities in access. So these are the kinds of things we're trying to identify and measure, and hope to provide some well-founded research to support advocacy. So where do we go from here? There is a need to marry the big population health goals for outcomes with the healthcare payment models that will incentivize achieving these goals. So this is where Dr. Behan was just talking. So we've already talked about the definition of population health, and this ties right into having value-based care framework where we can increase the value of the care that improves health. So the framework that I am most familiar with was proposed by Berwick in 2008, and this is the triple aim of trying to improve the experience of healthcare with improving population health broadly while reducing per capita costs. Easy, right? And this is, I think, ties very well to the definition of value-based care that Dr. Behan used, which was cost, results, and quality. So what we're trying to think about is how do we identify the current and potential value of radiologists within value-based care and how they are participating today, so that we can continue to advance their ability to contribute in these models. So research that we've done thus far is showing that radiologist participation in ACOs is growing. From 2013 to 2018, the number of ACOs where radiologists were participating grew from 10% to 35%. So you can see that reflected in this map. So there is growth that is occurring, and radiologists are finding ways to participate. What we're working on now is to understand how are they contributing, what are they doing within these ACOs, and where is this successful. So circling back, I've touched on the concepts that are shown here in terms of disparities, policy change, and how radiologists may be able to improve population health through screening. So what's next? Well, as we consider our framework for research opportunities into the future, we have quite a long list. So we have the opportunity to work with a broad range of claims data from Medicare and from private payers, and we actually just finished just successfully completed a fundraising campaign to get 100% Medicaid data for the U.S. For a couple of years. So we're going to be looking into all of these areas that I sort of broke into the categories of roles. So these are the roles that radiology and radiologists can play in terms of impacting population health. And then the tools that we have to help improve outcomes through each of these roles. So there's lots to do. Really excited about a grants program that we started this year that we funded a group of researchers who are looking at reinventing the radiation oncology model. So we're working with them to make sure that if this is our first big model for how radiology has its own alternative payment model, we need to make sure that it is incorporating the right factors to be successful. So that's what this project is all about. But would be happy if anyone is interested at any point to dig into some of the research that we're doing in each of these areas. So ACR is really committed to making a difference in these areas. You've heard about the commission, the Population Health Management Committee. We also have started an ACR Blue Ribbon panel on population health, and we are involved in leading the Radiology Health Equity Coalition, which ties into these initiatives as well, which currently has 10 organizations involved and is growing really quickly. So I think I've used my allotted time, so I will sign off and look forward to conversation at the end of the meeting.
Thank you, Dr. Rula. Much like what we just saw with Dr. Behan, it's very nice to see that there's a lot of parallel and congruency with what you talked about and what she talked about. And I'm very much looking forward to exploring those things further. I wanted to just remind the audience, if you have any questions, please place them in the Q&A. And we actually have quite a few registration questions that hopefully we can have time to get through. But thank you so much, Dr. Rula. I'd like to now introduce Dr. Ison, who will give us our final talk of the evening before we get to our panel discussion. Thank you for being with us today, Dr. Ison.
Thank you. I lost part of my controls. So thank you all for letting me hang out with you a little while. Hopefully we'll run through this and have time for questions. I want to quickly tell you about community healthcare, just so you know who we are. I think it's important to realize that we were started in 1986 with a mission statement from one physician. If you look at who we are now, you'll see we're still a relatively small company. If you look at everyone below the physicians, half the nurse practitioners did not exist in 2017, and none of the other specialists or partners there existed at that time in our organization. This has all come because of our move into team care. This just shows our locations. Again, the important part of that being that we are not big. We do not have outside funding. We've had to fund this ourselves, and that means that there's opportunities for anyone to do this. And this slide is not showing all. The next thing is sort of to look at our progression through our models of payment. We started out very early, of course, with fee-for-service, then capitation, episodes of care, payment for performance. Finally, moving into shared savings with some of our payers, into the ACO with SUMA, which we helped them found. We got into CPC Plus, which was a Medicare CMS demonstration project, and that really helped jumpstart what we were doing. That provided funding to support some of these other team members to help us develop some of this transition, ultimately moving to full PCP cap, which means we're capped for all primary care services, including anything we do in the office, hospital care, nursing home care, testing, that full bar. And then this year we moved into full risk with a private equity company called Agilon. The transition, as you can see, has really speeded up the last several years. So what were we able to do at Community Healthcare? Just to give you an idea, if you look at 2017 and you look at the cost of care in Ohio and Northern Kentucky for a Medicare person on a yearly basis or per month basis, you will see that in 2017, when we started doing team care, we started diverging at the cost. And we're able to get to the point by 2019 that there was almost, well, a little over $100 per member per month differential in what it costs if you were a patient at community healthcare versus in the state and average. Noting that this is Medicare and the payment structures are the same. So you're not looking at differentials in what hospitals get paid for contract. Even if you look at what happened during the pandemic, even though both numbers dropped, you see the differential or the delta maintained itself during that period of time. Of course, the thing that we always share is you can save money, but can you keep that money down and control quality? And does it develop over other models? So this is a Medicare MA plan in our market. This is not comparing different markets. This is actually the Summit County, Stark County market of Ohio. And the differential here is between community healthcare in the bottom and the rest of the ACO that we were a member of at that time. Most of that differential came through ER utilization, and that was mainly because of increased opening of hours and access. But were we able to keep up quality? We were the only 5-star plan in devoted health in Ohio in 2021. And of the 70 practices in the ACO for hypertension and diabetes, which is 2 of the metrics that primary care is measured by, we held several of the top positions in that ACO. So we did not lose quality while maintaining that cost savings. Team care, you've heard mentioned several times, and I want us to really think about that. You saw what community healthcare could do with team care just internally, just with our own practices. And if you look at a recent study published in May of 2021, and it redefined in their mind what primary care should be, it is all about interprofessional teams and teamwork. And I cannot even start to imagine or tell you what we can accomplish if we get across specialty teams working for the patient's best interest to do what's right at the right place, right time, right cost. I think the potentials here are just tremendous. This is Agilon's current locations. Agilon is a private equity company that we partnered with this year. As you can see, they're starting to spread rapidly across the country and could very easily be in your market already or soon. This shows their growth rate from 2017 to 2022 estimated, and how their lives are changing from 25,000 to 80,000 Medicare lives, the number of PCPs, very rapidly growing and moving. These are the kind of changes that are occurring that are going to change healthcare much more rapidly than it has in the past. This is what's allowed community healthcare to move into this model and go forward at this point. So I think one of the big questions becomes, who will be your payer, and will insurance companies be the people paying you in the future? There was 219 venture capital firms in healthcare in July of 2020. Although I don't have an exact number, I can tell you that that number has more than doubled. Oak Street Health is one of those private equity funded companies. They actually go in, set up their own clinics, hire their own physicians, do their own contracting. And their chief medical officer says full risk models, not shared savings, let health systems deliver what patients really need. Getting it down to the patient level, to their needs. Full risk, at least in our mind, allows us to do that. It allows us to move away from all those things that Dr. Behan talked about that have slowed down the process. It gets away from some of the regulations. We're away from competing and overlapping models. We're in one. We have the return to reinvest. We are now reimbursed for taking care of the patient, and that covers all the non-direct contacts. And that allows us to know who our high value providers are, who they're not. But when we get down to the equity issue, it also allows us to take our services to where the patient lives, to take it to their home, through home visits, hospital and home, through virtual specialty visits, where we can actually take a virtual visit with a specialist right into the patient's home or in our office. Our care coordinators to call, contact, arrange rides, help obtain food in some cases. One of our care coordinators is really big on getting food, and she'll actually go out of her pocket and buy food and take it to the patient's homes. Behavioral health in our offices, so you don't have to drive an hour away to get that. We have pharmacy management programs with PharmDs able to help us make sure we're controlling drug interactions. And community's been able to provide in-house home monitoring that comes directly to us each day. So we can know our patients' weights, our patients' sugars, their blood pressure, their INRs, their pulse ox, right in our office every day electronically without them having to call us. It just comes directly to us. The other thing I think that this model makes us stop and think about is in the hospital system, there are profit centers and there are loss centers. And if we are at full risk as a provider, we don't have profit centers anymore. We have resources to provide care for patients, resources to achieve the best outcomes for those patients. All of a sudden, the hospitals and high-cost specialties become cost centers and potential liabilities to the system if they're not making the kind of progression that radiology is through this group. I mean, you've heard some great examples of attempts to move forward and move into this field. But the PCPs in this model end up looking for ways to decrease costs, again, through some of the things we talked about, hospital home, potentially owning, or in my mind, more importantly, partnering with radiology to create independent, freestanding, in the community, and mobile diagnostic centers. Is this impacting big systems? Is this just something that community healthcare talks about? Are the big players involved? When Cleveland Clinic saw the graph that we showed you earlier, they decided that they wanted to do a joint venture with community healthcare. We just recently stood up Curbside QD, which is a MSO, which helps practices do their day-to-day operations, but also move into this area of value and take risk. So even they're recognizing some value in this model. I think the other question is, what's the next disruptors? We've got these private equity firms. We've got multiple different models to take risk, and they're growing quickly. There's also micro hospitals. Company out of Texas called NewTek. This is their website picture, and they're popping up these macro hospitals. They have ER, they have a very limited number of beds, they have limited services. As radiologists, this looks like to me a great place to start to partner. They will need services, they'll need cost-effective services, and they hopefully, because of not having so many loss centers to cover the cost of, be able to provide this cost at a lower cost of our healthcare system. They've just merged with a population health MSO about 3 months ago. So they're trying to deliver the full picture. In 2017, Dr. Zaidi did a presentation to community healthcare. And the presentation was about the same subject that he's still very passionate about and talking about tonight and arranging this. This was his list at that time of things that population health management partnership would look like. Working with physicians on appropriate imaging, which you've heard mentioned before. Following best practices, recommendations for potential neoplastic findings and other important diagnoses. Use data mining to evaluate outcomes and compliance. Having hospital-based radiologists manage patients across the care continuum. They were doing things at that time like follow-up programs for AAs out in the ER or for lung nodules in the emergency room. And of course, this all helps reduce malpractice risk and prevent leakage of patients. So he's been working on this for several years, and he is a great partner to work with, and it truly, truly understands the concept of partnership. As I was thinking about where we're at now at community and how do we partner, I started to realize that because we are now in the situation of having the full risk, all of a sudden the amount of income coming in to manage these patients becomes important. Medicare sets aside funding to the MA plans as well as its direct primary care model through what they call HCC coding or hierarchical healthcare coding. This is coding that's based on how sick CMS has decided the patients are, and they make that decision based on diagnosis codes. Lots of those diagnosis codes come out of radiology reports, assessments, and having that information included in the reporting can really help increase the revenue available to take care of these patients. So I would encourage you to think about including some kind of HCC coding education programs for your radiologists in the future. The other area that everyone has talked about is the quality part. In Medicare, that's a star rating. Star ratings are what rating the plan gets, and based on that, they get a different compensation to care for the patients. The higher the star rating, the more money the plan will get, or in this case, the providers who are in this model will get to provide this care. Radiology is absolutely uniquely in a position to help with these measures. Screening mammography, following up on abnormal tests, recall to this diagnostic test, the stuff that's been talked about, these are essential to being able to get a high star rating and improve that. Decreasing costs, I think those have pretty well been hit on. Provide concise readings and recommendations, potentially partnering with us in diagnostic centers. Access, been mentioned 2 or 3 times, weekends, evening access, being able to get that diagnostic test when you need it. If I'm in the office and I need a CT throughout a dissecting aneurysm or an acute abdomen and it's 5 o'clock, I'm going to have a real hard time getting that done now. But if we had good partnerships that we could get that done easily, and I can tell you when Dr. Zaidi was in our market as a radiologist, it was simply a call and he'd stay late and do it. But I don't have that happening all the time now. And also, we're going to need services to help support hospital home, which is a very rapidly growing concept for control cost. So the real question, I guess, is who will define your future? Will it be these private equity firms? Will it be this change in payer? It's scary because we'd like to believe that all physicians are here to do the right thing. But the one thing that I do hear from some physicians in primary care in this new model is anger and frustration. I would assume most of you have some idea that radiologists make on average 2.5 to 3 times what primary care docs make. And it's my prayer that we all partner together and we don't get into another tug of war that splits medicine and, more importantly, harms patients. With that, hopefully we can get to some questions.
Thank you so much, Dr. Ison. Gave us a lot to think about there. And it's great to see how these 3 talks have all touched on various aspects of really the same piece of the puzzle. And I would just invite all the speakers, if they can, to come back on camera. I'd like to start with the panel session. And we have a whole series of some questions that actually came through registration. I'd like to get to those, and also some questions that were generated by the talks themselves. And I just wanted to draw attention. Chris Hobson has this whole time been populating the chat with multiple links. And one of the questions I saw from the registration was, is there any formal training for radiologists in the emerging discipline of population health? Any recommended reading curriculum? So I think there's some fantastic material that Chris has put in the chat. As far as formal education, I know Jefferson actually has a population health school. In fact, I was the lucky recipient of attending a week-long course on that. So there definitely is training available, but Chris has some great starting links that he's posted in the chat. So I encourage you to copy those for later. First question I'd like to address to both Dr. Behan and Dr. Rula, because you both touched on it, and it's the concept of radiologists. And Dr. Behan, you mentioned that, you know, as a radiologist, we already participate in value-based care, certainly as part of MIPS. And I think you both had mentioned that, you know, as part of an ACO, radiologists can actually participate. But I wanted to ask, what currently is the role of the radiologist? A lot of the measures when we're talking about the ACOs, for example, if you're in an MSSP, they're really more geared right now for the primary care clinicians, or at least more patient-facing physicians, and a lot of those metrics are geared towards them. And I'd like to just explore with your expertise, what are the roles currently of what radiologists when they are participating in these different ACOs? Dr. Behan, maybe I'll start with you, and then we'll move to Dr. Rula.
Yeah, so I think it depends on the organization you're in, but also depends on your, what kind of value-based care your organization is participating in. And I think for radiologists, there does have to be some proactive kind ofness about it, just because, again, the attributed population is tied to PCPs, and sort of in some ways they unfairly kind of get tagged with everything, and that includes the total cost of care. And so I think that in it, sort of the total cost of care is really kind of a way to start to look in terms of, what are the drivers of that care? Are there actually imaging costs within that care that are actually, opportunities for appropriate reduction? And so I think really it is, engaging with those folks who are already engaged in value-based care, developing those relationships, and then finding out, how can I contribute? And I'll tell you that if people do that, if somebody, again, Dr. Rao is very engaged, Dr. Lee, you're engaged. But I think that if folks would come up and say, hey, how can I get engaged, specialists in particular, I think most folks who are sort of day in and day out doing value-based care would love that.
Yeah, and that's part of our job, is to sort of spread that word to the radiologists, because it's not necessarily a part of what they do day to day. Mm-hmm. Dr. Rula, what are your thoughts?
Well, I guess it's interesting to me that at this point, this has to be a question for radiologists. I think going back a long ways, I've heard radiologists referred to as the doctor's doctor. And in that case, if radiologists are a key part of the care team in advising the primary care doctor, then surely they should be part of ACOs and helping these organizations provide higher value care. Part of that is helping to control utilization and eliminate waste. And part of that is making sure that whether an exam is needed or not is one way of doing that. We also have to make sure it's the right exam. And radiologists are best positioned to help make those decisions. And then, of course, making sure that the follow-up care and for a patient is aligned with their specific diagnosis, and that they can consult with the doctor in terms of the pathway of care and additional tests that may be needed to make sure that patient has the best outcome at the end of the day. I just really think that radiologists play an important role in the big goals.
I'd like to pick up on the last portion of what you mentioned about clinical decision support. And so it's been, as you know, and as probably most of the audience knows, been delayed several times. We're still in our educational phase. As of right now, as of January 1st of 2023, we're supposed to be using it, and at that point there would be penalties for not submitting the correct information. But what is your thought on where clinical decision support is going at this time?
I would say that that other areas of the ACR are much more directly involved in the clinical decision support piece, but I think it's critical. And when you talk to people to radiologists and outside of radiology about where radiologists can participate, that is a key area. When we think about value-based care, we need to make sure that the care that radiologists are providing has the highest value. And if you aren't placing some responsibility and accountability on radiologists, and also responsibility for referring physicians to heed that, to follow that guidance, then we're not going to have the highest value care.
Yeah, I really do think that clinical decision support does have a lot of potential. And if we even pivot to, we currently use CDS, and what is the most appropriate study, which I think is important, but even pivoting to a subset segment of CDS is, should we even order the study? And a lot of the appropriateness that we're now seeing coming out of the different committees really are building that in. So I think there's a lot more that CDS could do. Thank you. I'd like to ask this question to Dr. Ison, just to follow up, and this was actually a question that was also posed in the registration as well, regarding COVID. How was your practice experience during COVID? And are there any lasting changes in your care delivery model that will stick in the post-COVID era?
Luckily for us, because we were moving into population health management, we had already created virtual visit technology, already had it in place. So except for the scare of our payment model and the lack of visits and the lack of income that we saw for the first couple of months, financially, we did not see a big hit with COVID. Our biggest hit was providing care. And what we saw with COVID across all specialties was lack of access. And we've seen now multiple patients with delayed diagnosis who couldn't get testing done at the time they needed it. Specialists wouldn't see them. And much to my surprise, what I'm afraid is going to be the persistent outcome is we're still seeing lots of physicians who will not see patients in the office and are only willing to do virtual visits. And that's making it very hard to get the kind of complete and accurate treatment. So I guess I'm more scared about the downside of that lack of access that doesn't seem to be improving as quickly as we had hoped it would.
How do you
The other thing real quick, if you're talking about this, the thing that's frustrating me as a physician is the fact that I have to order the test, period. I would love to be able to say to the radiologist, this is my problem and this is what I want to find out the answer to, and let you do that. And I know the current payment systems don't allow for that, but full risk does, because I'm the payer now.
And picking up on that, since you in your talk, you talked about how you're now assuming the full risk. How has that worked out for the network? Has that been a positive thing or a negative thing, assuming both sides of the coin?
I think it's going to be a positive thing. I think it's going to allow us to get to the point where we've got the kind of data. That was the reason we decided to go with a partner like Agilon. As it's, I don't know if it's Behan or the data is so hard to get. And they have the kind of capacity to generate that kind of data, so we can see where high value is, we can see where we need to use the specialists and help educate them. If we use it as a tool to beat people up, it's not going to work. If we use it as a tool, much like the stuff you're doing with your organization, to help find the right answers and the right way to do this, that's how we accomplish good outcome.
Agreed. Well, thank you all. I'd like to ask one final question to all of you and sort of tie everything together. In the previous webinars that Dr. Zaidi and I have done with Chris Hobson, we've really presented population health from what we thought was a radiology-centric area. And I'd like to ask you, from your perspectives, from each of your perspectives, for this final question before we end the webinar, what do you see as the role of radiology in population health? We talked a little bit about what it currently is doing, but I'd like to ask each of you what your thoughts are on what you would like to see from radiology in the population health setting. And why don't we start with Dr. Behan?
Yeah, sure. So I think it's a little bit, there's I guess a couple of answers to that. So what we need is more advancement in terms of our payment models that actually can allow for participation of more specialists. I think that there is a role in particular for episodic payments, and that could be both acute and also longitudinal. And really radiology being, when you think about all the providers involved in, particular conditions, you see radiology along with pathology and whether it's cardiologist and those docs in the hospital or on the outpatient, really being all part of that value chain, I think, of providers. And it's really an integrated service line, if you will. And I think that's where really not only radiology, but other providers will participate. And that includes primary care. I think that's down the road a bit, but I think I do think that I think that they're seeing from private payers and even CMS, they're really focusing on, involving more in value-based care and not just primary care.
Great, thank you. Dr. Rula?
Sorry. I would agree with everything that we just heard. Payment models are the thing that will most quickly initiate change. But I think every little step forward can help. So we need data that shows that value. So if you're doing work, measure it. That's how we'll make the little steps forward that will build into this bigger picture of where we're headed. I think just a lot of the smaller initiatives that I hear about that are underway at the health system or hospital level really fall into this category of finding ways to be more accountable for the patient's pathway of care and being part of the care team. So I think that's just kind of a big open opportunity to make sure that the radiologist is considering where that patient ends up after they leave their office. And I think that's a huge opportunity.
Yeah, the research you're doing at HPI to highlight and bring to light these disparities is going to be critical moving forward, especially in the population health setting. And I think the three of you have actually highlighted the importance of data and how ultimately we're going to get it and mine it. So thank you. Dr. Ison?
I think from my standpoint, what I control as the PCP, seeing a patient in the exam room and needing access, radiology is the most critical part for the part I have the most control of. If I can't get access to testing, if I can't get it when I need it, if I can't keep that person out of the ER, that's the biggest cost savings and value to my patient I can possibly bring. So I think it's a starting point of all this. The data, yes, it would be lovely to be able to show all this, but if we wait till we can show it, the ball's going to be gone. It's going to be too late. So I think we have to start by talking, communicating, doing things like this, sitting down with the PCPs in your markets and saying, hey, how can I help you? What can we do together? How can we make this work? And access being one of those real keys. If I could have a radiology-owned, round-the-clock diagnostic center in my market tomorrow, you would hear me shouting.
And hopefully, thank you, Dr. Ison. And you've confirmed, and hopefully it's not just because this is a radiology webinar, but I think you've confirmed to Dr. Zaidi and I the importance of radiology in a population health setting. But I would like to thank the three of you. Thank you for your presentations. You've given us a lot to think about and how much more work we have to do as radiologists in a population health setting. But it's great to see, to hear that we are all aligned. So with that, I'd like to turn this back to Dr. Pyatt.
Thank you so much, Dr. Rula, Dr. Behan, and Dr. Ison. I appreciate it.
Okay, Jen, if you can take us to the next screen, please. I would like to thank our faculty tonight and Dr. Lee, our moderator, for such a robust, interesting presentation. Every speaker's quality was great. The PowerPoints were really good. And this discussion has been fantastic. This has been quite a program. I'm so happy we have it recorded, and I hope it's shared widely in the radiology community. Okay, I just have a few final comments. So please share your feedback with us we will be sending out a post-webinar survey to all of tonight's audience, and the recording will be available next week in its entirety. Our next Power Hour topic will be on governance structures for private practices, and this will be held on August 24th from 7 to 8:30 p.m. And between now and then, you'll be receiving more information about that. And you can register for that program and other RLI Power Hour webinars at acr.org/Power Hour. Again, thank you to our superb faculty and our superb moderator, Ryan, Dr. Lee, for tonight's program. And we hope everyone has learned a great deal. And there are many opportunities, it looks like, in population health for radiology. Thank you and good night, everyone.
Thank you.